Thank you.
I welcome Dr. Vara Laxmi. She is a consultant critical care in Pinnacle Hospital, Visakhapatnam. She will be speaking on ideal ratio in massive transfusion. Dr. Vara Laxmi Divakarla.
Thank you, sir. Namaste, everyone. First of all, thank you, ISCCM Hyderabad, for giving me this opportunity. Really means a lot. Thank you so much. I hope I'm worth the time that all of you are spending here. So, uh, we've already gone through this. That there's a large trauma is contributes significantly to global morbidity and mortality. We moved from fluid to crystalloid to blood, then finally now we are give what is lost, that kind of a stage. One third of patients, even before they at admission to the hospital, they are coagulopathic. Then around 3% of civilian trauma patients, 7% of military trauma patients need or are candidates for massive transfusion. Now, how do we go about this massive transfusion? What strategy should we use? We all understand now that there is trauma-induced coagulopathy, that it's a complex phenomenon. And we know that damage control resuscitation, damage control surgery has led to the idea of hemostatic resuscitation. And underlying all this is that human physiology is basically anticoagulant. We survive because we are there is very few anticoagulants in our body in comparison to the procoagulants. And so after all this, we all know, all of us know 1:1:1 and 1:1:2. These numbers are ingrained in our minds from the time we do our post graduation or our first year of training in critical care. But the question I am supposed to answer is, have we identified the ideal ratio in massive transfusion? So back from the days of conflict in Iraq and Afghanistan, that's when a lot of studies on massive transfusion, trauma, resuscitation came into being. And then these surgeons who worked in Iraq and Afghanistan, they went back to trauma centers in the US and they conducted a lot of studies. And this a landmark study by Bogman et al., they found that as the ratio decreases, that means the lesser amount of FFP and platelets you give versus a pint of blood or a bottle of blood, the mortality will keep on increasing. So then lot of observational studies came, small single center studies, a few patients, tens, hundreds of patients, which showed an evidence towards benefit improvement in mortality when fixed ratios were used. Then this one important prompt study came about. This was published in 2013. Basically, it's only an observational study. What they did is 10 US level 1 trauma or adult trauma patients. And in all these observational studies, what was reported, what was found was that there is a lot of confounding. Because if a patient doesn't survive the first 30 minutes, he won't be eligible to get any of the products, right? So it doesn't mean that because we are giving lot of in ratio transfusion, it's actually because of a survival bias, because the first 30 minutes people are dying. So it was thought that that is leading to a wrong kind of an impression about fixed ratio transfusion. So they wanted to look, they did a minute to minute observational study, trauma patients. So they started monitoring everything. Which minute the patient came, what were the vitals, when was the first blood PRBC started, when was the first FP, and so on and so forth. So if you can look at this bar graph, although the intention was to give a fixed ratio, whether it is less than 1:2 or one is more than 1:1, it was found that patients actually did not get, even though there was an intention of giving, lot of patients got the fixed ratio, or they reached that fixed ratio very, very late during the resuscitation phase. It took them almost 3 to 4 hours for them to get some kind of a balance and ratio going. So that was the finding from this study. So this was an observational study. So later on came a randomized control trial, the proper trial. So in this again, two groups, 1:1:1 versus 1:1:2. They wanted to compare these two. Interestingly, they found that there was no difference in 24-hour mortality, 30-day mortality. None of these was significant. But if you look at the lower end of the column, hemostasis was achieved more and earlier in patients who got 1:1:1, number one. And death by exsanguination, where just patients just bleed to death, that happened lesser when the ratio was 1:1:1. So again, no mortality benefit, but they found a signal towards uh, something good happening, exsanguination not happening, hemostasis being achieved. So after this, a few systematic reviews also came, which looked at small groups of trials. There was too much of heterogeneity. So none of the systematic reviews were able to give concrete answers. But most of them said there's not much difference between 1:1:1 and 1:1:2. But still, it was thought that some kind of fixed ratio is the way to go. Then came a group of surgeons, again trauma surgeons. They started working the math out. They started looking at when we look at massive transfusions, what we essentially mean when we break down a bag of whole blood into PRBC, platelets, and plasma. But what we forget is that when all of them are given, say, for example, a bag of PRBC, a bag of FFP, and a bag of platelet is given back to the patient, it is not exactly what we have taken out that is given. We add lot of anticoagulants. There is a lot of degradation that happens. It can be platelet degradation, it can be RBC degradation that happens when blood bags are made, when fractionation is done, and then patients get back these. So for example, this cartoon, if you give 1:1:1, then the hematocrit, average hematocrit of after you give, it will be around 29%. Plasma will be around 64% of plasma coagulation factors, and it will give around 90,000 platelets. So doesn't sound like a good deal, right? If you go to 1:1:2, it gets even worse. Hematocrit is of course 38%, but plasma coagulation factors are only 52%, and platelets, you are only giving 60,000 platelets. The same is depicted on the other chart. So if you see all the gray, those are all the additives, the anticoagulants, the extra fluid that is added. So the main purpose is to prevent hemodilution, and you are indirectly doing the same thing again. So that slowly garnered attention, and then it started making news. The same people who were against these fixed ratios, they came up with this sort of a curve. So they developed this curve based on some physiological parameters. We all understand that there is a primary hemostasis whenever there is endothelial breakage. So platelets, there is endothelial activation, and then platelets will go and sit there. That is primary hemostasis. Then the coagulation factors will all come there, and then the platelet will form a plug, RBCs will come, secondary hemostasis. So coagulant factors are important for secondary hemostasis. Now there are rheological studies on blood flow have shown that hematocrit also plays a lot of importance, because when flow is laminar, what happens is the platelets are at the peripheries, they are at the walls, the RBCs are in the center. So for this to happen, there has to be a certain amount of hematocrit. Most studies have shown that it has to be at least 30. That means around 10 grams of hemoglobin has to be there. Some studies have even shown the maximum efficacy goes up to 50, and then there is not much difference. So, and we all know that in a normal, we have seen a lot of coagulation abnormalities, that if coagulation factor levels are 30 and more, usually patients are asymptomatic. So that is near about what we want at the least. In addition to that, in trauma, we have to remember that there is ongoing blood loss. So they assumed that we'll hike up that number slightly. So at least 40% of the coagulation factors have to be there. And hematocrit, they assume that a 30% is what is ideal. So if you can see the purple line, that is the curve that we are working on. If you give factors, so you don't want to enter the left side sort of the curve. You want to stay on this small part of the curve. If you can see there in small numbers, that number starts from 1:1 and it ends somewhere at 3:1. So even if you give 1:1:1, it is a very borderline case. If you are giving very ideal numbers only, you will be able to maintain the required amount of coagulation factors and a required hemostatic state. Because we all have to remember that although the function of the blood is carriage of oxygen, that is RBC function, the other essential function of the blood is hemostasis. So if you want to attain hemostasis, 1.1 may be okay, but it is very conditional. It's giving a very small margin. So even if there is a small error, a small bout of bleed, then most likely things go haywire. Another hypothetical calculation they made. If if a patient loses 1 to 1.5 times blood volume, there is exchange, then what happens is about 25 to 37%, depending on whether it is 1.5, of native blood will remain in the body. Now, actually, this is the reason. It is this hemostatic buffer which saves a lot of our patients. That is the reason when blood loss is more than this, most of the patients, they bleed to death. So, okay, these are not working. Ratios may not be working. How about goal-directed therapy? Just now we heard a wonderful lecture on this. Two ways, conventional or viscoelastic. Europe, they started actually using viscoelastic testing long back, almost last 20, 25 years they've been using it. So in a good, robust ICUs, they performed this itactic study that sir was quoting. They were not able to find any difference between when they used a viscoelastic assay versus not using it. So it was surprising, but there were a lot of flaws in this study because they measured the parameters at 4-hour intervals, and 4 hours is a lot in a trauma patient because they wanted to measure the conventional and the viscoelastic at the same time for the study to be valid. In that process, I think they lost out. Another interesting observation was made by another study actually. What they did is, the flaw with itactic was, although they found abnormalities, they were not able to correct those abnormalities. And we all know measuring has never made a difference to any outcome. It is what we do out of that monitoring that makes a difference. So overall, viscoelastic testing also not much assays. So now they're again coming up with whole blood and a low titer uh, O positive whole blood. So what about government directions, societies? What do they say? Whole blood, the only indication is exchange transfusion in neonates. This is by the Indian authority, and it can be used only in major bleeding when ratioed blood is not available. Again, in massive transfusion, 1:1:1, that is throughout by the Indian, American, and the European. There are small changes in the European guidelines which also recommend usage of cryoprecipitate and fibrinogen as a part of the initial trauma massive transfusion management. So how do we go about it? We also know there is another layer to this, that is trauma-induced coagulopathy. Now we understand that there are a lot of phenotypes. There are bleeding phenotypes. Some patients bleed more, some patients become thrombotic more. It was considered early and late, early being the bleeding type, late being the thrombotic type. But we've also seen a lot of literature about mixed. So there is this underlying another layer of complexity to our decision making. And lot of phenotypes are being studied. There are certain phenotypes based on biochemical parameters patient factors, hemodynamic parameters, which are telling that there are certain group of patients who don't fare well. They bleed more, they are more coagulopathic. So giving all this information, if we self-reflect, have we identified the ideal ratio in massive transfusion? I think the answer is a massive no. Because in fact, there may be none. I don't think there is an ideal transfusion ratio, so we will never find it. So how do we go about things? Number one, get basics right. Early identification, MTP activation. Don't forget the diamond and the triad. Plasma, if when you're starting, you start with 1:1:1. Lot of centers have started using 2 pints of low titer O whole blood upfront. Right away they start with that, because one line they can start giving it, and then they get their empty massive transfusion bags, and then they start giving, because simultaneously giving 3 products is very, very difficult. Access, lot of challenges, thawing times are different. So, but you can start with 1:1:1. Try to maintain your goals, restrict crystalloids, give calcium, and then maybe if you have access, do a rapid TEG. If you don't have TEG, if you have given more than 4 RBC units in an hour, then maybe you have to consider platelets and cryoprecipitate along with everything else. If you have rapid TEG, then depending on the numbers that you get. Also remember, stopping bleeding using damage control surgery, Riboa, compression, tourniquet, anything that it takes for us to stop bleeding. That is probably the way to go. Lot of studies are coming up. The TROOP trial, the SWIFT trial, and digital artificial intelligence, machine learning, lot of studies are happening. So hopefully we should have better answers in the future. Thank you so much. Like to take this opportunity to encourage all of you to donate blood. Thank you.
Thank you, ma'am, for that enlightening talk, and then we'll invite you for questions later. Next, we are moving on to